Good afternoon. How is everyone today? This is really loud today. My name is Jamie Nill with the Knox County Chamber of Commerce, and we are here today for our State of Healthcare, for our State of series, which is presented by our great sponsors at WVUB PBS. So throughout the day, throughout our luncheon today, they will be taping for to have on our website, to have on their website. So if you want to go back and watch at a later date, you absolutely can do that. But again, today is presented by WVUB, but our program sponsor today is Good Samaritan Hospital, Good Samaritan, as well as our gold sponsors, Guardian Angel Home Health Care and Bridgepoint Health Campus. And our supporting sponsors are Family Health Center, Good Samaritan Foundation, and Guardian Angel Personal Services. So thank you to all of our sponsors who have made today possible. We appreciate all the support. So as I say during the beginning of each of our State of series, this piece, we try to do something once a quarter, kind of just to bring some information to you that's maybe happening at the state level or things that are getting pushed down that will be affecting our communities. So, you know, the other State of series that we do is State of Workforce, Education, and Government. So today we are moving forward with our State of Healthcare, and we have two great speakers that are going to tell us a little bit about what's going on in their world. So today we have President and CEO of Good Samaritan, Rob McClin, with us, as well as Dr. Michael Drake, Chief Clinical Officer with Family Health Center. But we're going to kick off our program today with Rob McClin. Thank you, sir.
Well, you have one great speaker and me. So Dr. Drake will be far better. I want to start by doing a little introduction too. And I'm a roamer, so I get to wanting to move, and I'm being told I can't move. So if I start reaching out too far, somebody reel me back in. And I'll try to stick with the script a little bit more today. So it is really good to have all of you here. My name is Rob McClin. I'm the CEO of Good Sam. I've been with the organization for 32 years, and I've been the CEO for the last 14, working on 15. And a little bit about Good Sam. We are the first county hospital in the state of Indiana, opened our doors in 1908. We're independent, have remained independent for that same period of time. The good thing about being independent is we can be a little more of a speedboat than a system. But the bad thing about being an independent organization is there really are no safety nets. So when we make a mistake, everybody goes, well, what are we going to do to pay for that? And so it's really critical that we kind of stay on top of things. The other thing I want to say that I'm happy to announce is that from a relationship standpoint, we're going to maintain independence. We're not selling to Deaconess. If you haven't heard that rumor, I get it like 17 times a day. So please go out and tell your friends, not selling to Deaconess. We've stayed independent. I will say this, independence doesn't mean isolation. We do a lot of things in collaboration with a lot of different hospitals, especially Deaconess, St. Vincent, Evansville, and IU. And we'll talk a little bit about those as we go forward because they are huge partners that bring a lot of value to us and do a lot of things that we don't have the capacity to do. So that's the key of this whole thing. We as a regional center of excellence with 11 counties that we serve and 250,000 population, we recognize that there are things that we have needs for that we're never going to be able to do in a rural area like this. But having partners like IU Health and having partners like Deaconess and St. V gives us that latitude to be able to expand our services, be able to do some things in partnership that otherwise we would just have to simply ship. So it's really important for that. Is this thing supposed to be on? I have no looking from behind. So I'll start with this slide, a couple of the current challenges. And this is no different for Good Sam than it is for any other hospital, the 170 hospitals in the state of Indiana. Dealing with rising costs, declining reimbursement, narrow margins, most of the time either at break even or even a loss, and then the rising costs of healthcare to employers and the rising costs of healthcare out of pocket to employees. We're going to talk a lot about all of those and kind of what things we're doing. But when we talk about reimbursement, I wanted to give you a little bit of an analogy because healthcare is so different than other entities as far as how we're paid. So I walk into a hardware store and I want to buy a power driver, screwdriver, cordless drill, and it's $200 on the ticket. And the cost to that hardware store for that is $100. So I go up to the cashier and I give him $200 and I walk out. If I'm covered by insurance, to make this analogy closer to what hospitals deal with, if the hardware store were a hospital, the cashier would first ask, what's your insurance coverage? And I would go, I'm with Good Sam Direct Health. And they would go, okay, well, based on the negotiated rate, that $200 price tag on there, we're going to sell it to you for $125. And I'd be going, that's great. Then my dad walks in, my 80-year-old dad walks in, wants the same cordless drill for $200. Medicare. Cashier says, you get it for $57. And then my nephew goes in who's on Medicaid. And they say, well, how much is it for me? I'm on Medicaid. And they say, well, we'll have to sell it to you for $45. Now, both those last two examples were under their $100 cost. So how long do you think a business, a hardware company, or any other business could work under these reimbursement methodologies, relying on Rob, the commercial guy, to be able to cover the costs of the losses from my dad and my nephew who are on Medicare and Medicaid? That's what we deal with every single day. So the question becomes then, how do we move forward? I hate not being able to see that back there. How do we move forward? What kind of partnerships are we using from a hospital standpoint to work with both the state, national, and even local organizations so that we can kind of flip this narrative of healthcare is too expensive, there's no way to get around it, we need to avoid healthcare at all costs. And so one of the things that we have done, and I think is most important, is that we've worked with a company called a collaborative. We were one of the initial members of the Indiana Business Health Collaborative. This is a group of statewide Hoosier employers and providers that have worked together to, one, focus on lowering the cost of healthcare without jeopardizing quality or access. And those are really key. I mean, we can talk all day about how do we become cheaper, but cheaper doesn't make it better, and you cannot make mistakes in healthcare. So you have to be high quality if you're going to expect people to want to come to your hospital and trust you. One of the things that I wanted to, let's see if I got it here, share with you is a couple of the members. So this collaborative is comprised of a bunch of statewide businesses, large and small. A lot of providers. You can see Good Sam on there, which is one of the founding partners. Cummins, Cook Medical is on there. Lilly, the Indiana Chamber, Indiana Farm Bureau, Elevance is Anthem. So all of those are a big play in what we're trying to accomplish as an organization in looking at ways to infuse new ideas, reducing costs, making access more available, and making the costs lower. One of the things that I think has been key for us, now that I know I've got this under here, I really don't need all these others, is creating a mission with that IBHC that focuses solely on what are the right things to do for the Hoosiers in this state. One, focus more on lowering costs by having direct-to-employer partnerships. Secondly, constantly focus on outcome-based models, because it shouldn't be just Good Sam or any other provider gets paid this amount regardless of what the quality is. It ought to be predicated on quality-based product, right? Quality-based outcomes are the health and the well-being of the patients at the forefront of everything that we do. And if not, then we don't belong in this business. And so our focus is always on that. Maintaining a healthy workforce, one of the things that is really critical is you got to have people healthy enough to work every day, keep the cost down for them, keep the cost down for the institution, and then the ability to attract, retain, and maintain a quality organization with quality employees, world-class employees on a daily basis. Those are absolutely critical. And the overall purpose behind the mission was to just advocate for effective change in healthcare. All the things I said, as true as they are, doesn't preclude the need for a change. We have to change if we're going to be successful going forward. One of the first things that the IBHC did was commissioned the Indiana Fairbanks School of Public Health to do a report on just the overall quality of healthcare in Indiana. It included what the spending costs were, the impact on employees and employers, the market characteristics, the mortality rates, public health investment, major demographics. And I want to share with you a little bit about those because there's some pretty interesting things. One, the good news is that the summary of findings on this shared with everybody throughout the state and the providers and a lot of the businesses with the IBHC's help was that there really isn't a remarkable difference in what nationally you're seeing in the healthcare spend and what's going on in the Indiana market. Well, that was good because if you've heard of the RAND reports, the RAND reports didn't say it that way. RAND reports were saying Indiana's a mess, your costs are too high, we can go to Michigan or Kentucky and have a lower cost provider and a lower cost outcome. And what we've done through the Fairbanks is kind of debunk that, showing that the data they were using was a little flawed. This is pretty good data, and so we've been able to show that, hey, there really hasn't been a remarkable difference between nationally and Indiana. But that doesn't stop from the question of what are the differences, because there still are differences. So when we looked at those differences, a lot of it related to the fact that just Hoosiers are paying a lot more out of pocket. And then the question becomes, well, why are you paying more out of pocket in Indiana than you are in other states across the country? A lot of it is the high deductible plans. So many of you may be on them. Good Sam has an option for a high deductible plan. Right now, the data says that 31% of health spending is paid by insurers and 30% is paid out of pocket. That's a big number. That is a lot of money at today's costs. So how do we lower that? What are the things that we ought to be doing to try to improve upon that and lower that percentage down for those that are paying out of pocket? We talk a lot about direct contracting. We talk a lot about tiered contracts where we drive steerage back to organizations that lower their prices. And I'm going to discuss all of those in a little bit and give you a little bit better idea of what that looks like. Another difference between the state and national was that Indiana had a lot greater shortage of physicians. Fewer physicians result in less access, delayed access, and a higher cost. So for us, we wanted to try to address that, and we're going to discuss a little bit about our own residency program over the course of the last 5 years in just a moment. Another difference was Indiana's mortality rate, 16% higher than the national average, which is not good. And so when we looked at that, we were asking questions about why. There are a multitude of reasons. When you do a community health benefits analysis, you notice that it's inactivity, a lot of diabetes, obesity, smoking. In fact, the smoking rate in Indiana, so the smoking is higher in Indiana, which is 16%, than the U.S. It's higher than that in Knox County, which is almost 19%. So for us, all these things go into play with our collaborations. We collaborate constantly with the Knox County Health Department, working with as many of the local entities as possible to address things like smoking cessation. How do we deal with infant mortality rates? Can we do things better, more efficiently, bring people here to get them better care at a more timely rate than what they're getting right now, regardless of ability to pay? How do we address those things? And then finally, I think the work that we've seen from the city, more ability and opportunities to be able to get outside and engage in activities that allow us to get a little bit healthier. Whether that is bike trails, the new bike trail on Washington Avenue, pretty nice. Whether it is just trails for hiking, the ability to get out, be more active, and reduce some of these dramatic numbers will be a big key as we go forward. And it's all about collaborating and bringing that relationship together. And we'll talk a little bit about our partners in a few minutes. Some of the other key stats from the Fairbanks report, one is that Hoosiers, the percentage of Hoosiers covered by Medicare and Medicaid increased by 21%. Good Sam right now is running 57% Medicare and 15% Medicaid. So 72% of our patients and our pay come from government payers. Revert back to my hardware analogy. 72% of my payers are paying us at costs below cost, which is really difficult. The second part is, well, then how are you making that up? And I'm making that up through the commercial side. But the commercial side is only 24% of our overall business. So when you see those numbers, you can see why, from most perspectives, Good Sam is break even on a good day. And those things have to change. Because what happens when you've got a Good Sam with 72% government payer mix and they're losing money, those costs get shifted over to the commercial payers, which is not fair. It's not equitable, but it's the only avenue that we have right now, like every hospital in the state of Indiana. Those are big deals. Also, Hoosier spend actually is pretty good. Overall spend is actually a little bit less than the national averages and has dropped by 7% since 2020. So there's some things that we've worked on across the state that are making that easier and a little more affordable for the Hoosiers of this state. So what are we recommending? There were some very specific things that were being recommended from the report. One, that self-insured employers, that they ought to be able to manage costs by directing patients to centers of excellence. Couldn't agree more. Good Sam wants to be that center of excellence. And what that creates is an opportunity to be able to tier things so that there's steerage back to hospitals like Good Sam that are willing to invest in high quality, great staff, and great outcomes. And that affords us the opportunity to be able to negotiate lower rates, better rates for those employers that want to work directly with Good Sam. We'll talk a little bit more about that. Also, they talk a lot about offering HDHPs. You know what that is? High deductible health plans. High deductible health plans are a thing. But without the second part, the HSAs, the health savings accounts, it puts a lot of burden on the employee, because that high deductible is great because you get a lower premium until you get sick. And then you got to figure out, how am I going to pay $3,000 out of pocket or $5,000 out of pocket? What the health savings account does is afford you the opportunity to be able to set some money aside tax-free that can be used to fund that deductible. Sometimes employers even do that. Good Sam's doing that on behalf of our employees right now that take the health savings or the high deductible plan. So there are a lot of different opportunities to be able to do that. Employers also can form purchasing alliances. So when we talk about that to get better rates, I'm going right back to the dialogue we've just mentioned: direct contracting, work with local providers, do things in concert that allow us to keep that steerage here. Value-based models, I think it's really important. You can see the word accountable care. Good Sam's been part of an accountable care organization since 2022 with CVS. And what it's allowed us to do is work on quality-based outcomes, work on things like creating a dedicated Medicare wellness program, clinic, remote patient monitoring, chronic care management. In 2025, we're getting ready to now refocus our efforts on collaborative care with nursing homes, home health care agencies, skilled nursing facilities, all things to attempt to lower the cost and minimize the times where patients have to come to the hospital. It seems so counterintuitive, but the reality is our focus going forward is on how can we do more to keep patients out of the hospital, because the chronic care patients are the ones that are creating the highest volume of visits at the lowest cost impact, highest cost impact, lowest reimbursement to the organization. We need to catch these individuals earlier, do things in a lower setting, lower cost setting, whether it's convenient care clinics that we've set up, Wellness Matters clinics for employers. Those are the kind of things that as we go forward, we really have to continue to strive to get better at. The hospital assessment fee is kind of the next step on this. So all the things I've just talked about are absolutely the God's honest truth. But the reality is everything we do still comes down to the state and federal government paying providers at levels that at least cover our cost. Right now, they're not. So for us, what we've been working on over the last 2 years and really heavily in the last 6 months, if you know anything about politics, you know that Indiana is going into the long session with the legislators beginning January, and it'll run through May. Our focus at that time, and has been really for the last 6 months, in working with not only the incumbent mayor, but the incumbent governor, but the new governor coming in, is to educate them, along with the state, the Senate, and the House, educate them on the opportunity for the hospitals in Indiana to benefit from a new HAF redesign. So let me explain HAF, which some people call HOF. It's not HOF. It's HAF. Hospital assessment fee. It's a tax that's paid only by hospitals across the state of Indiana to the tune of $1.5 billion that I'll show you a slide on. Those monies are then taken at the state level and able to be matched against federal matching funds that bring monies back into the state of Indiana to help offset the low reimbursement rates that we get from Medicaid rates right now. So I'm kind of getting a little ahead of myself, but that's basically how that works. Two things to point out on here. One, the tax is only paid by the state, by hospitals in the state. Secondly, the redesign that we're looking at, and then we want to talk through and give you a little better explanation, is to increase reimbursement to hospitals. No new state funds are needed. It has no impact on the state budget, while at the same time we tie everything to quality-based outcomes, quality-based metrics. So if we're not doing the right thing and grabbing this money and it's not showing an improved care, then we shouldn't get this money. And so that's been the real design that we tried to work on. It's called the State Directed Payment Program. 38 states in the country already have this program in place. So what we've tried to educate our legislators on is 38 of them have already done it. It's not new. And the reality is, if Indiana doesn't participate, those monies just continue to go to the other 38 states. So why are we not partaking in something that would benefit this state, not impact your budget, and improve the quality of health care going forward, and enhance the margins to the point where hospitals could actually start reinvesting back in things? That was really key. So we are working on that. Right now, everything that we've calculated, if they went with this state-directed payment program, it would generate an additional $800 million back into the state of Indiana with no impact on their budget. So it's a big deal. I want to talk to you a little bit about kind of how it works. Indiana hospitals right now, Medicaid, hasn't increased since 1993. So think about the difference in reimbursement from now back to 93. Think about your costs. Have wages gone up? Have supply costs gone up? And so what we've had to do over that same period of time is create all kind of supplemental payments to help fund or improve the funding of the Medicaid program, again, at no cost to the state. But even with all that, and I'll show you right now, we're currently getting 57 cents on every dollar of cost. So for a Medicaid patient coming through our doors, we're going to lose 43 cents on every dollar. Cost, not our charge. We are losing, as a state, about $2.7 billion in unrecovered costs from the Medicaid population. That has to change. The thing that really lights us up when we talk about this, and the fact that we've put $1.5 billion into the program to get federal funding, is that the state of Indiana withholds 28.5% of that, doesn't go to get matched at the federal level, and puts that in a different bucket that's supposed to be used for health care. We're not sure where it's going. We're not sure how it's being used. But I know $300 million is not going to get matched against the federal level that would have afforded us even better reimbursement. Not that I'm bitter. One of the things that I think is really important, and I've already showed you these, I don't have to do it again, but I want to personalize it for you. So the $1.5 billion in HAF tax, the assessment, we don't call it tax because it's a bad word. It's an assessment. It's a tax. Good Sam, our portion is $16 million. The amount that the state withholds, that 28.5%, is $4.5 million that we don't know that actually comes back into the healthcare coffers. So you look at the $16 million that we pay to try to get advanced funds, and I'm still only getting 57 cents on the dollar of cost. Here's the other benefit of the half redesign, is that we anticipate by being able to do this, one, we've set the design up in a way that the money follows the patient, which is absolutely imperative. So the dollars are going to follow the Medicaid patients based upon where they are going, what organizations they're being cared for at. The second is, we believe by doing this, it'll afford us the opportunity to be able to lower costs in a way that will not force us to cost shift as much as we do the commercial side. Second really good thing. And then thirdly, right now, it will bring the reimbursement levels of Medicaid from 57% up to 80%. That sounds great. We have to remind ourselves that's still a 20% loss, but it is dramatically better than what we're doing now, and it's a great start, and it's already set in place with other states, so there's really no reason that we shouldn't be able to see that happen in the state of Indiana. That's going to be our focus and our drive over the course of the next 5 months. We are already started through the Hospital Association, lobbying dramatically, and I'm going to share with you a little bit of information on what you can do to help us as well. So, what are we doing to improve the cost? All that sounds great, but you still want to know what's Good Sam doing to improve the costs of healthcare and to assure good outcomes. And one of the things that I'm really proud of is that our big focus has been over the course of the last couple of years is to create our own insurance product. And why would you create your own insurance product? Well, we believe that by being able to do that, we can direct contract with employers in our region and afford them a lower cost, a lower premium, steer patients through a tiered approach to Good Samaritan that improves our volumes, that allows everybody to win. This partnership is with SIHO, Southern Indiana Hospital Organization or Healthcare? Health Organization, thank you. A great partner. And we've had this up and running for the last 2 years. We've employed, we've actually taken this on as our insurance product at Good Samaritan and our 1,800 employees. And in our second full year, you see the list of the direct health members. Sunrise Coal is a little unique. You know, they have 1,000 employees that we're working. They have a different plan, but we have a direct contract agreement with them, so we are working in concert with them. Goal again, cut out the middleman, lower the cost. And we're really proud of where this has gone. Feedback has been excellent. We're looking to continuously grow it. Doesn't matter the size of the company. It can be 1,000, it can be 50. So we're working with everybody. And I think it makes a huge difference in the long run in being able to keep our costs down and pass that on to the employers and ultimately to the patients. The other thing that we've done is offer up some clinic-based partnerships. So this direct contracting that we feel is so important to be able to see those patients and those employees at their locations, minimize that downtime for the employer, minimize the times that they're having to come in a catastrophic situation to the hospital and stay for 5 days. We've got clinic-based partnerships in Indiana, Illinois with Toyota Boshoku. I don't know which one. It's one of those two. One in Lawrenceville, one in Princeton. This is going really, really well. We're in Robinson, Illinois with Hershey, Robinson, Illinois with Marathon, and we want to continue to grow those. We have a Wellness Matters clinic that we utilize for employers here in the community that are out by the community care clinic on Willow Street. Another great opportunity to be able to utilize a lower cost setting to be able to see patients at an easier avenue, easier access, and lower cost than coming through our ER. The highest cost and the highest loss area in the organization is our ER. So we want to keep you out of the ER. We want the ER for those emergent traumatic events that we absolutely must take care of. If we can keep people going to these clinics, lower cost, better access, everybody wins. The other thing that we had mentioned earlier was the low physician shortage in Indiana. One of the things that we're really, really proud of at Good Sam and really in southern Indiana is the advent over the last 5 years of SIGMEC, which stands for Southern Indiana Graduate Medical Education Consortium. SIGMEC was designed by 4 hospitals, Good Samaritan, Deaconess, St. Vincent, and Jasper Memorial, with the focus on starting up residency programs to be able to retain more doctors in Southwest Indiana. The current program comprises internal medicine, psych, both of them at Good Sam, with part of the internal medicine at St. Vincent, family practice, which is at Deaconess and at Jasper Memorial. Psych program right now, we have 6 new psych residents per year. It's a 4-year program. So at the end of, during the 4th year, we have 24 psych residents roaming around. Same time, internal medicine is 16 per year. We try to keep 6 here, 10 down at St. Vincent, 16 a year for 3 years. That's 48. We have a lot of swings at the plate when they graduate. Over the course of the last year, when the full graduating class came out, really proud to say, and you can't read any of that, so don't worry about it, is that we've retained 50% of the psych and internal medicine residents in Southwest Indiana. That's a big deal. That is a huge deal, and that's what our focus has been from the start. We'd like to get that up to 60 to 65%. That would be the going rate for us as we continue to grow this thing. So a lot of good things happening that we're really proud of. And then the other thing is the collaboration that's necessary. It can't just be Good Sam. I talked to you early on about Deaconess and St. Vincent, IU Health, but it's also the collaboration with some of our local organizations, whether it's Wabash General Hospital in Mount Carmel, working with them, working with Lawrenceville, working with Gibson down in Princeton. All those hospitals bring a wealth of opportunity for us in collaborating on residencies, rotations, doing things together in a partnership that will reduce costs overall to the people that we serve. And then I'd be remiss not to talk about the Family Health Center and the incredible work that we've done together to be able to bring the Family Health Center in, collaborate on taking over the Samaritan Center, which is outpatient behavioral health, working with primary care, and their predominant focus is on Medicaid patients. What makes that so beautiful is that the synergy there is Medicaid loses money for me, but I've got a partner that can actually gain a margin and create an opportunity through Medicaid. And so that partnership has been huge, and it's been something that we've been really proud of. You're going to hear more from Dr. Drake a little bit on that because it has been a big deal. The other that is something that is a rarity, and I've been across the state and I've listened to a lot of scenarios, our relationship with the Knox County Health Department, we're a unicorn. Most relationships in most counties and the hospitals don't exist. They don't work together. They don't like each other. We were in a place where we've really had a good relationship with Dr. Stewart, with that team, working on everything from the smoking system we just talked about to all the community health needs that we have that we're going to work together and collaborate on because the money's flowing through. The First Indiana Fund goes through the county health department. What's nice is there isn't a, that's mine, don't touch it. It's a, we're going to work together to figure out how to do this at the lowest cost possible in a partnership effort so that the outcomes are there for the patients that we're so privileged to serve. That is really the big deal for us. So collaboration is huge. Can't do it on our own, and we really have worked hard on building relationship and trust with these other organizations. And then how do you help? I've got you a list up here that I need you to start writing and calling today. This group is going to be the part of Southwest Indiana and Knox County that will have an impact on whether half redesign goes through, whether we continue forward with continued reimbursement through the Indiana GME board, which is for residents and grant monies. Right now there's a $45,000 per resident grant monies we get from the state on an annual basis. That's up for consideration. Right now the state is funding that to the tune of $7 million a year. We've built enough over the course of the entire state. We've built up enough new slots for resident programs like Good Sam's that cost is going to be about $8 million. So we're going in asking for an increase to be able to ensure that we cover those costs and continue to have the opportunity to keep more of those residents in the state of Indiana, because it's proven through the data that a resident will stay 65 to 70% of the time in the area and the location where they did their residency. So once we get them in, we've got a 60 to 70% likelihood of being able to keep them. And that's huge. You don't want the brain drain out of the state of Indiana anymore. And we've got a lot of medical students coming out of IU and coming out of Marion that need to have residency programs here locally. So Eric Basler out of Washington, Matt Hostetler, Evansville, Mark Messmer, Jasper, but he's really our new senator. Todd Young, senator, and then Mike Braun. If you have an opportunity to be able to utilize your voice to help us with these things, let us know. Through the Hospital Association and through Good Sam, we've got a lot of data. We can share a lot of information with you that will help, I hope, get the word out and educate them even more. There's really no loss and no downside to the state accepting the plans that we put together for the assessment fee and the state-directed payment program. And then the other thing that you can do is, I would love every employer in Knox County to be a member of the IBHC, because what I want is more of a presence of Southwest and Southern Indiana on that IBHC. Right now, it's a lot of larger cities, so it's the Fort Waynes and it's the Indianapolises and even Columbus with Cummins. But what we want is a presence in Southern Indiana that reflects on, hey, we have issues too. And we're dealing with things as a rural county and a rural region that others don't quite understand. And the one thing that we constantly educate, I was going to say attack, we constantly educate legislators on is to remember that there are a lot of other Hoosiers and a lot of other hospitals outside the 465 loop, because that's all they want to think about. And the reality is, we have to do things a little differently here too. And so when they do things to address things out of Indianapolis that negatively impacts the smaller hospitals outside of the 465 loop, we become collateral damage. And then everybody loses. So it's a huge deal. And we're excited about the opportunity to be able to go before them again. We need your help. We need your voice. We have really good people. He's got a great story. Marketing, he's got a great story. And I will say this, I think the one thing that I've been most proud of in this organization over 30 years is the focus on treating every patient like they're the only patient in the hospital, focusing on every individual, not like a number, but like a person, somebody that we go to church with, somebody that we go to the grocery store with, somebody that is related to us in some way, because in Knox County we're all related. And that makes an enormous difference. And I never want to see that change. That's why the independent side is so important to me, because it allows us to continue on that focus and maintain that independence in a way that every individual coming through these doors is treated special. And that's what we want. Thank you.
Quick question for you. When someone wants to talk to find out about the Good Sam Direct Healthcare, who do they need to contact?
We'll start right now with Adam Thacker, Chief Operating Officer, and then he can get in contact with the right people through SIHO and work it out. But I would call up to administration. Let us work with it first. Okay. Yeah, and we would love to have more partners. We think it can make a difference and keep costs down.
Thank you.
All right, thank you.
Thank you, Rob. I appreciate that. And another side note with this Good Sam Direct Healthcare, you guys, this is just another opportunity for us to provide to our businesses here to help retain those employees, because we can offer health insurance. So definitely reach out to them about that. In conjunction with Good Samaritan and SIHO, at the chamber, we do offer a plan for those employers that have 2 to 50 or 2 to 49 employees. So we definitely can get you information on that. So those needs are definitely being covered here in our community. So, and as Rob said, please go join the IBHC so we could get our voices out there and be heard for our community. Next up, we're going to bring up Dr. Michael Drake with Family Health Center.
My name is Dr. Michael Drake. I am the Chief Clinical Officer for the Family Health Center. Prior to that, I was a part of the Good Samaritan Hospital family under the Samaritan Center. I've been here with the Samaritan Center, Good Samaritan Hospital, and now the Family Health Center for 34 years. Next year marks year number 35. So seen a lot of changes in the state of healthcare over those 35 years. And we're currently going through a transformation in the state of Indiana for behavioral health care. So I'm going to talk a little bit about that and the impact of that transformation on the community. So currently, the Family Health Center serves two populations or provides two primary services: primary care services and behavioral health care services. The behavioral health care services are under the auspices of the Division of Mental Health and Addiction, and we are functioning as a certified community mental health center. The primary care services are under the HRSA and functions as a federally qualified health center. So that is their funding mechanism. The Community Mental Health Center in the state of Indiana covers all 92 counties. There are 24 services, or 24 agencies, providing services to over 300,000 Hoosiers in the state of Indiana. The Community Mental Health Center system was set up as a safety net organization for Indiana residents. And that is that we are able to provide quality services and protections as a safety net organization for those individuals who lacked maybe the ability to pay for those services or seek those services privately. So we're here to serve everybody with behavioral health services. As a community mental health center, we're integrated into every aspect of the community. We work with the court systems. We work with social service agencies. We work with Good Samaritan Hospital to provide a continuum of care. To give you some background or some statistics about the Community Mental Health Center here in Knox County alone, last year we served over 4,300 unique individuals from Knox County. The Family Health Center serves over 8,000 unique individuals a year. So 4,300 of those individuals that we serve were residents of Knox County for behavioral health services. This is not, that 4,300 does not count the primary care services that we provided. We did 1,105 of those 4,300 received both substance use services and mental health services. So not only is it emotional problems that we're dealing with, it's the substance use issues that are plaguing the county at this time. We provided over 24,000 therapy appointments. Now that does not include our medication clinic appointments, our life skills training appointments, drop-in appointments, the clubhouse, all the other services we provide. One-to-one individual therapy, we provided over 24,000 sessions last year. We performed over 1,200 initial evaluations. That is, people who had not been in services or weren't currently in services, so new clients to the behavioral health system were provided last year in Knox County alone. Average time for that initial visit. In Knox County, we've been able to knock it down to about 2 days for adults. We have walk-in services right across the street here at our Bayou office that allows us, somebody shows up at 8 o'clock in the morning, they are getting an evaluation that day, whether it's for substance use disorder or for serious emotional disorder. So 2 days we can get you in. Children and adolescents is a little bit different. We don't have the capacity or the capability to do the walk-in appointments. So it's taking up to 21 days or 3 weeks to get those scheduled. I can tell you right now the demand for children's services is so high that our Willows office is scheduling into January already for those initial evaluations. For that, what happens though is, as an adult, we can get you in within 2 days. But our next follow-up appointment that we can get you in for is going to be over 3 weeks out. Our schedules are so full. I highlight these statistics just to emphasize the demand for behavioral health services in Knox County alone. But this is a nationwide trend. Behavioral health is being recognized as more and more important to the functioning and the health of society as a whole. So a state of transition. Indiana is currently transitioning from the Community Mental Health Center system that was set up in 1962, or in the 60s, to what is called the CCBHC, or Certified Community Behavioral Health Clinic system. Here's the big difference, and as Rob talked about with the reimbursement structure, the community mental health center is no different. We rely heavily on Medicaid for our reimbursement, and there were years where we weren't able to break even. The funding was not sustainable. Under the CCBHC system that we are transitioning to, the difference is that it adds a crisis continuum, which I'm going to focus on later in the speech, but it adds, it changes our payment structure. Using Rob's hardware store analogy, when you go, let's say you are Medicaid and you're coming into the hardware and you're going to buy that drill, it's marked $200, but then Medicaid says, well, how much did it really cost you? Well, by the time we pay the stocking clerk, we pave the parking lot, we have to pay rent on the building, utilities and everything, it really cost us $250. Okay, well, that's what we're going to pay you. So under CCBHC, we're going to what's called a prospective payment system. Right now, we're under fee for service. So when you come in and you receive individual therapy, we charge, for example, $100, we get paid $45, as an example. Right? Under the CCBHC system, we submit our cost report, and instead of one reduced payment, we get an accelerated payment for those individuals. So the true cost of providing service is what we're going to be reimbursed for. The state in the community mental health center system has always imposed on us what we call unfunded mandates. You have to provide this service, you have to do this for the clients, things such as providing transportation, et cetera, but we're not going to pay you for it, but we're going to make you do it. So now, under CCBHC, we're able to consolidate all of those together, and here's the true cost of providing service. To be a part of the CCBHC system, we have to increase access to services. The goal in increasing those access to services is 0 days to wait for an evaluation. If you need services, you show up at our facility and you're going to get the help that you need. The biggest benefit to the community for CCBHC is the reduction in cost. How do we do that? One of the ways is through our continuum of crisis services. CCBHCs have been shown to decrease emergency and inpatient hospital admissions. Now Rob's like, hey, wait, don't mess with my hospital admissions or my emergency room admissions. But again, the majority of our clients are Medicaid clients. He's losing money on that. We admit a mental health patient to an emergency room that doesn't need to go to that emergency room. They're tying it up 3-4 hours where they could be providing a service to another client that is in medical need of that service. So we're decreasing costs by diverting those unnecessary emergency room and hospital admissions. One CCBHC that's already established, there are 10 designated states that already have the CCBHC system in place, reported a 75% reduction in emergency room admissions, inpatient admissions, and a 64% reduction in emergency room visits. Now, it doesn't sound, they also saved $99 a month in costs on each client. Doesn't sound like a lot, but for that system, that $99 a month for each of those patients added up to over $25 million that they were able to save the state and or other organizations from having to pay. And again, that reduction in costs at this point stems primarily from the establishment of that continuum of crisis care. So to look at the need for crisis services, in the United States alone, in 2021, over 48,000 people committed suicide. 6,500 of those individuals were between the age of 10 and 24 years old. Each year, over 12 million individuals have thoughts of suicide. It's through outpatient services that we're able to assess, triage, and support individuals with either mental illness or in a crisis situation. We can avert suicides. We can avoid hospitalizations. We can provide an alternative to individuals in crisis. The Family Health Center was awarded a contract by the Division of Mental Health and Addiction to establish a crisis continuum of services here in Knox County as well as our other catchment area. Why did they do that? They gave us a big check. The reason they did that is because it is an essential requirement of the CCBHC system. We are mandated, there we go. Somehow there we are. Oops. Okay. As part of the CCBHC system, we are required to have that crisis system up and running. The state of Indiana recognized that for small community mental health centers like us, that was going to be impossible without support. It's a big process. It is a whole different way of providing crisis services in the community. It requires a lot of staffing, as you'll kind of figure out when I go along to tell you about all the things that we're doing. The crisis services have to contain or be comprised of three things. The first is a dedicated crisis line, and we call that someone to talk to. The second is a mobile crisis team, that is individuals going out in the field, and we call that someone to respond. And then the third component is the crisis receiving and stabilization services. And then finally, crisis receiving and stabilization, and that's a safe place for help. The first is the crisis line. Now, as Samaritan Center, Good Samaritan Hospital, we always had a dedicated crisis line, a 1-800 number that anybody could reach, and it actually was throughout the United States. Okay. So as the Family Health Center, with the Green Door Center, development of the Green Door Center, we had to establish our own crisis line. So hopefully everybody has the business card. It's staffed 24 hours a day, 7 days a week. The call is answered by certified peer professionals and or a licensed clinical social worker. And one of the things that the crisis system really relies on is the incorporation of what are called certified peer support professionals. Now, what is a certified peer support professional? A certified peer support professional is you and me. It's anybody. It's someone, they don't have a degree in mental health. They've not gone to school and earned a bachelor's or a master's degree. They have a high school diploma, hopefully, or a GED, but they have what is called lived experience. And that is, they either have a history of mental illness themselves, or substance use disorder, or they have a family member that they had to manage and help and support. So they have lived what people in a mental health crisis are experiencing. They go to training, they have a certification program through the state of Indiana, and so these individuals are relying on their own personal experience. They can tell you what it's like when you're feeling this way, and here's how they managed it. They're not doing therapy, but they are there to support the individual having a crisis. Through that line, we also do a safety screening. Every client that calls in, are you feeling like you're going to hurt yourself? Are you going to hurt anybody else? Are you safe in your environment? How can we help you? What are we going to do? So we're there to talk them through the situation. I provided emergency services in the emergency room here for many years, many more than I want to remember. But when I was on call many a time at 3 o'clock in the morning, I would show up in the emergency room because a mental health patient had walked in. They just needed to talk to somebody. Okay? So the crisis line is there 24 hours a day, 7 days a week. We also are coordinated through Indiana's 988 Crisis and Suicide Prevention Line. Now, what does that mean? We are designated now as a crisis responder in the state of Indiana. if someone from Knox County calls 988, it will go to the central office, or the central 988 center here in the state of Indiana. Then they will transfer that call to us here in Vincennes at our Green Door Center. Or they may dispatch one of our mobile teams, call up and say, hey, we need you to go to Bicknell to this person's house and help them out. Okay? So we have that agreement and contract and certification with the state of Indiana now. The whole idea behind the crisis line is to triage and point that person toward the appropriate level of care. So the next item in the continuum is the mobile crisis team. The mobile crisis team is someone to respond. And I want to use this analogy. Let's say you are having knee pain, and it's pretty significant. You can't bend your knee, you can't get up off the couch. But guess what? To get services, you got to get up off the couch, get in the car, go all the way to the doctor's office, the emergency room, whatever. Remember back in the day, doctors used to make house calls. Well, that's what the mobile crisis team does. Instead of bringing that individual into the hospital, instead of requiring that individual to come across the street for an appointment, the mobile crisis team can respond in the community to that individual in crisis where they're at, whether that's the middle of Walmart, whether that is on the street, whether that is outside the emergency room at Good Samaritan Hospital, anywhere. So instead of requiring that individual to leave the community and come into an institution or another building, we go and we meet with them where they're at. Okay? Requests for deployment can come from anywhere. That is a family member, an individual seeking assistance. They can call us up and we'll go to their house. It can come from law enforcement. It can come from a business. Walmart can call and say, hey, we got somebody having a meltdown in aisle 4. Can you come and talk to them? And we will go and provide those services there. As a matter of fact, a couple months ago, I was on my way to work and stopped by a local convenience store to get my 32 ounce to take to work. And there was an individual on the bench sitting outside, visibly in distress. A couple minutes later, when I get to work, I tell the mobile team, I want you to go down to Cash and Dash. There's somebody sitting outside in distress. And they went and they helped that individual and was able to prevent the escalation of a bigger crisis. You don't have to be a client of the Family Health Center to receive services from the mobile crisis team. So we do help existing clients, but you don't have to be a client. We will respond to anybody in the community. And just because we respond doesn't mean that you have to become a client of the Family Health Center either. We are not going to force anybody into services or sign anybody up for anything. We are there to help and to respond to that crisis. I talked about cost savings earlier through the crisis continuum that we can provide. And this is data information submitted by the state. A mobile crisis team dispatch costs $300. When we send the team out, Medicaid will pay us $300. That's what our reimbursement rate is. That same individual, if we're able to divert them from the emergency room and or an ambulance ride, that is $2,200. Okay, so a $1,900 cost saving right there. If law enforcement has to be involved, and that person, because there are no other options, has to go to jail for the night, that's $2,400. Okay? So if we can go to the scene, make an intervention, connect that individual to resources, then we're able to realize that type of cost savings. The team not only can resolve the situation where the person is at, we can transport the individual. One transport that we have done, this person was plagued by substance use disorder, and they needed to go to a treatment facility in Evansville. We were able to, instead of making them go to the emergency room, get medical clearance or anything, we were able to directly take them from Knox County to Evansville and get them admitted into that treatment program. The other place that we can transport them to is the Green Door Center Crisis Receiving and Stabilization Services. What does that mean? It is an option or an alternative to the hospital. It is an alternative to the emergency room. It is not an inpatient unit. Okay? It's not long-term treatment. But it is a facility where we can work with an individual for, our goal is 23 hours and 59 minutes or less, in order to resolve the crisis or the situation. The crisis receiving and stabilization services are staffed by a case manager, a peer support professional, a technician, and at least one licensed clinical social worker. Okay? The purpose of the CRSS is to prevent unnecessary hospitalizations or incarcerations. Believe it or not, that a lot of time law enforcement, because they don't have an alternative at this point, has to take somebody who is in emotional distress and trespassing. They have to take them to jail. Or maybe they're intoxicated, but it's not, it's public intoxication, but it's not a criminal offense. You know, where do you take them? What do you do? Do you lock them up overnight, or is there an alternative? Could we seek treatment for this individual? It's an opportunity for us to connect that individual with Family Health Center services or any other organization services that they might require. Again, services are open to any individual. They don't have to be a Family Health Center client. All services are voluntary. Our doors, the exits are not locked. No one will ever be restrained. No one will ever be detained. If someone is there, 10 minutes later, they decide, hey, this isn't for me, I'd rather go abuse a substance, or I don't like it here, they are free to go. Everything is voluntary. The CRSS is governed by what we call a no wrong door policy. And what that means is you may be in a crisis. It may not be a mental health crisis, but you need some type of service. When you walk in our door at the Green Door Center, we're going to connect you to the service that you need. Okay? It's not, you know, I'm homeless. You know, I'm okay. I'm not going to kill myself. I'm not having a breakdown. I'm just homeless. I need some place to live. We will connect you to those services, or work to connect you to those services. We can't solve homelessness, but we work with the agencies and the resources here in town to connect that person to what they need, potentially averting a crisis situation down the road. Okay? The CSSRS is a living room model. What does that mean? That means it's not an institutional setting. It isn't a hospital room. We don't have any beds. The closest thing we have is a couch and recliners. And so it's meant to be different than an institution or hospitalization. It's, hey, you're with other people that are having the same or similar problems, or that have experienced those problems. The staff sit with the clients, not behind a desk, not behind a nursing station. They're there interacting with those clients to resolve and help them de-escalate that crisis situation. So. We can provide essentials, food, water, clothing, some basic things to help someone. There's nothing worse in a crisis situation. Someone, and the staff laughed at me when I made them get these supplies, but with the crisis team and even with the crisis receiving, if you're in a crisis and your shirt is covered with mud or blood or puke, you know, or maybe you don't even have a shirt or a pair of shoes, we are stocked. We have paper shirts, we have paper shorts, we have flip-flops, anything to return that dignity to that individual so that they can feel more composed and able to get their thoughts together. So, future services at the Green Door may include nursing and medication. We are not equipped for that at this time. But that would also be a possibility, is instead of, you know, we get the person calmed down, we get the crisis resolved, but it's going to be another 3 weeks before we can get you in to see the psychiatrist to get you on any medication. We will be able to provide that service in the future as well. We're located at 300 North First Street. If any of you remember the old Fresenius dialysis, and before that it was outpatient surgery. It looks like a depot with a green roof. Yes, so that is the Green Door Center. We're currently undergoing some major renovations. A lot of banging going on, a lot of drilling. The crisis call line and the mobile crisis team can respond to individuals of any age. The crisis receiving and stabilization services at this time only accepts adults 18 and over. That's what the renovation is about. We're basically kind of splitting the building in half so that one side of the crisis receiving and stabilization will be for adults and the other side will be for children and families. So by the time that renovations are completed by the end of April, we will be able to start servicing children and families age 3 and older. So I think that is the end of my slides, so thank you.
Does anybody have any questions? Yes.
Mm-hmm.
So many people pack guns now. How do you handle it?
We are doing metal detection, okay? One of the things that we do before we deploy the mobile crisis team is that we do a safety assessment. Are there guns in the home? You know, anybody can lie, but if we ask the question, we feel that it's safe, then we go through a list of safety factors, make that decision, deploy the mobile crisis team. Someone comes in to the Green Door Center for Crisis Receiving and Stabilization Services. We do have the metal detector. We make them empty all their pockets. We assign them a locker and secure all of their property and valuables. Just let you know, yes, we have had several people already taking advantage or utilizing the Crisis Receiving and Stabilization Services and the mobile crisis team. We've had several deployments with that. I know we're averaging or increasing. We're up to about 75 calls a month last month, and it just keeps increasing every day. We're getting more and more calls. So we are finishing up with the adult side in our renovations, and we'll start doing a major marketing campaign at the beginning of the year, 2025. So.
Any other questions?
All right. Thank you.
And on your tables are the cards with the phone number for the Green Door. So I'm sure if you want some of those for your business to take back, we probably can get a few more for you just so you can have them handy in case you or your employee or someone in your facility might need that information. So, well, thank you all for coming today. Thank you to Rob and Dr. Drake for their time. I appreciate it. And thank you to our sponsor, Vincennes PBS, as well as our program sponsor, Good Samaritan Hospital, and then Guardian Angel Home Health Care, Bridgepoint Health Campus, Family Health Center, Good Samaritan Foundation, and Guardian Angel Personal Services. So thank you again, and everyone enjoy their afternoon. Have a good day.